Hey guys, welcome to another episode of Health Matters with yours truly, Danielle Linane. I have the pleasure of sitting down today with Dr. Kevin Windom. He's a gynecologist here at Wellstar Kennestone Hospital, has 26 years of experience, but has specialized in urogynecology. Care to learn what urogynecology is? Grab your pens and paper and listen in. Hey guys, I am joined today by an old friend of mine. We were just talking about that. This is Dr. Kevin Windom.
Hello all.
Hello all. So Dr. Windom and I go way back. We used to operate together in the operating room. But Dr. Windom, tell them a little bit about you. They hear me all the time. So tell them a little bit about you, your background, where you came from, who's your mama, all that.
Well, before I tell them about me, I'm going to tell them about you because I don't think you ever told them about you. I've known her since she was a tech in the operating room and probably not too long out of high school.
I was 21 when I started in the operating
21,
room.
And I cannot even believe she's here, much less interviewing me. Now I don't even feel like I should even be here because I feel like I'm not worthy of her even interviewing me.
Gosh.
Where she's come in her life is fantastic, and she wouldn't say that about her, so I want everybody to know that about her.
You're the sweetest.
So how did I get here? So I grew up in Savannah. I went to the University of Georgia, and I went to the Medical College of Georgia. Thank you. Go Dogs. And then I did a year of internal medicine in Memphis. And then I did a 4-year residency in OB-GYN in Denver. And when I was in Denver, urogynecology was a new thing in the OB-GYN world, and I was interested in it, and there was a person there that I trained with who had a fellowship, and I was going to stay for his fellowship. It was a 1-year fellowship. And then he decided to turn it to a 2-year fellowship, and I'd already done 5 years of residency, and I was like, I got to pay off student loans, and I can't keep on doing this. And so I said, thank you, but I can't stay for 2 years. But when I was the chief resident, I had the ability to just kind of schedule whatever I wanted to schedule. So I just pretty much did the urogynecology stuff that he did. And then, fast forward to now, I'm a board certified urogynecologist and a board certified obstetrician-gynecologist. And so when I was looking for jobs, I looked in Denver, I looked in Savannah. My wife's from Austin, Texas. I looked in Austin, and I looked here. And interestingly, the job here, they really wanted someone who did urogynecology. They kind of knew what it was. No one in Atlanta was doing it. No one in Atlanta was doing it, but I came here, and then I met other doctors, and then a lot of other doctors in the community wanted to see what I was doing, and some of these guys, I was kind of spellbound by them. And then as time goes on, my practice has just morphed into something different. In 2013, the American College of OB-GYN decided to make urogynecology, but they call it female pelvic medicine and reconstructive surgery. But I just say urogynecology because it kind of makes it more sense. They decided to make that a true subspecialty. So there's 4 subspecialties in OB-GYN. There's high-risk obstetrics, maternal fetal medicine. There's infertility. There's GYN oncology. And then now there's urogynecology. And so people like me were allowed to see if you could grandfather in. And so it was... The first year, I didn't even think I would even be able to grandfather in because I did so much other stuff besides urogynecology. But people throughout the country who knew me and said, you really should do this. And so I submitted the list, and then I qualified. Then I was an interview, and I guess I did okay on the interview. And then there was a test that I had to do a review course for the test because the test was like an extensive 6-hour test, and I passed, and here I am. Right. So I'm double board certified in OB-GYN and then in urogynecology.
So tell the listeners the difference between the two.
So urogynecology, I'm kind of like a bridge between urologists and gynecologists.
Okay.
So if you just think of, female anatomy, there's a bladder, there's a vagina, there's a cervix, a uterus, tubes, ovaries, a rectum. And so the first thing that comes to mind is like urinary incontinence.
Yep.
And for the longest time, urinary incontinence would be seen by a urologist. Well, a urologist, they're very good at this, and but a lot of urologists are seeing men. Not a lot of urologists do gynecology, and so someone like me understands how it all is intertwined. And then for the longest time, a person who had urinary incontinence, or let's just say they had problems with bowel movements, and they had a gynecology problem, they'd have a gynecologist doing surgery on them, along with a urologist doing surgery on them, along with a colorectal surgeon doing surgery on them. I'm kind of one-stop shopping. So that's sort of how it works out with me. But because I've been in private practice for so long, I've been here 21 years. And so
you've been at here.
I've been in the same job for 21 years. So
you deserve an award.
I know. And to you millennials, y'all don't even understand staying at the same job for this long. Hey, but you've been here at Wellstar that long.
They can't get rid of me.
Yes, well, you're getting so high up. I mean, the next move is the CEO, I think.
No.
So I've been here so long that, I started just a private practice, and I would see just regular patients. I did normal obstetrics, normal gynecology. And then as time goes on, when you do surgeries like I do in urogynecology, people would say, hey, do you feel comfortable doing this surgery? Yeah. Or, hey, I have a patient with this. Do you feel comfortable doing this? And the next thing you know, I become a catch-all. If it's not cancer, they probably send it to me.
Right.
So as time goes on, I have my private practice that's just a revolving every year patients that I see. And then I have a business in like infertility surgery. A lot of infertility doctors send me surgery for people who need surgery before they do in vitro or surgery for their infertility. I do endometriosis surgery. I do fibroids, taking out fibroids and that surgery. And then I do like the complicated gynecologic surgeries that other gynecologists don't want to do. And then I do my urogynecology. So as time goes on, I kind of morphed into that.
You wear a lot of hats.
I wear a lot of hats.
You wear a lot of hats in the GYN world.
Yes. And so when you end up having a surgical subspecialty, things kind of just change. But I still take call from my group. I still do obstetrics. But as time goes on, my midwives are so popular, and my midwives do a lot of the deliveries, and I mainly just do C-sections.
Okay.
And so I do a lot of C-sections.
Okay.
And a lot of people, and I also do C-sections. I do a lot of C-sections, and oftentimes they're the C-sections that, like I said, nobody else wants to do, and so I'm happy to do them.
And now, is that just like patient history, maybe just complications, high risk, and those types of things?
Correct.
Right?
Like the person who's on her 5th C-section.
Right.
Or the person whose placenta has grown into her uterus.
Right.
Or the person who has had multiple abdominal surgeries. Or the person who is very, very, very overweight. Right. Those are the ones that I end up doing.
Okay. All right. Sounds like fun. So I want to talk specifically. So one of the things that I used to do a lot with you was a lot of your pelvic floor reconstruction. Talk a little bit about that, kind of what type of woman qualifies for that, and what are those surgeries? I know that's kind of a very broad question for you. But,
no, I get it.
Yeah.
So pelvic floor surgery is a kind of a catch-all. And in the reconstructive world, it's almost like a reconstructive surgery, and that's why female pelvic medicine and reconstructive surgery, that ends up, people like that name better than urogynecology because it kind of says what it is. But the majority of those types of surgeries come from obstetrics trauma. Okay. And so a woman has a vaginal delivery, and it's not uncommon that just the delivery process, you could tear connective tissue, and connective tissue that holds the urethra in place, and then you could end up having urinary incontinence, mainly coughing and sneezing, leakage of urine. You could have uterine prolapse, like your uterus is falling and it becomes pelvic pressure, pelvic pain, sometimes pain with intercourse. Yeah. You could have hernias where your bladder is a hernia into the vagina. Some people have a hard time peeing, or they have to lean forward or stand up over the toilet to pee.
Yeah.
Or you could have like a rectocele, which is a hernia where the rectum bulges into the vagina. And those people sometimes have to lean backwards to have a bowel movement, or even worse, they have to put their fingers in the vagina to push down to have a bowel movement. And so all these things are things that not many women want to talk about.
Right.
But when they find out that it's like a normal thing to have and there's a fix to it, they're thrilled.
Right.
What I always hate is the person who sees me and maybe comes to me through a friend or something, and she's complained about this problem for 10 years, and unfortunately she gets the story where it's just part of being a woman, or it's part of having babies.
Right.
That's part of the deal. Well, it really doesn't have to be part of the deal.
Right.
There's
Maybe
definitely,
it used to be, but
yes,
not anymore.
And there's definitely fixes to it.
Right. So what are some of the ways, so like I know you do, are you still doing the mesh? Are you still doing like mesh? And I saw too, you're doing robotic. Mm-hmm. So talk a little bit about your robotic stuff.
So the mesh thing real quickly, the mesh thing has been real litigious.
Right.
And as far as fixing hernias, if the bladder falls into the vagina, it's a hernia. The rectum bulges into the vagina, it's a hernia.
Right.
A general surgeon's going to fix a hernia with a mesh.
Right.
So gynecologists in the early 2000s said we should be fixing these hernias with meshes.
Right.
So gynecologists started, and companies started coming up with these meshes. And I worked with companies doing this. And then the next thing is companies would come to people like me and say, do you mind showing other gynecologists how to do this? Sure. But then the other gynecologists wouldn't feel comfortable doing it down the road. And so then it was, hey, is there any way we can make this surgery easier for the general gynecologist? Well, easier for the general gynecologist is also easier for me. Yeah. So sure, we can show you I could do this or this and make it easier.
Yeah.
Well, then meshes became the rage, and then lots of gynecologists did it. Mm-hmm. And then, unfortunately, sometimes people who weren't trained as well as they should have been were doing the surgeries, or there was a false sense of security that some gynecologists had, and there were multiple problems. And so then as time has gone on, in 2011, the FDA came down with we need to look at meshes more. And then as time has gone on, now meshes are totally off the market for pelvic floor reconstruction. They still have meshes for slings, and they still have meshes that I do robotically, but the other ones are off the market. But what I tell people, the analogy that I tell people is, I've done meshes the whole time and I haven't had a problem.
Right.
I do biologic grafts like porcine grafts, cadaver skin grafts, but the mesh is not the problem. And the analogy that I use is silicone breast implants.
Yes.
In the 70s, when silicone breast implants came out, plastic surgeons, gynecologists, general surgeons, everybody was doing that surgery. And a lot of people who shouldn't have been doing that surgery were doing it. And so because of that, there was a lot of problems with the surgery. Well, they sued Dow Chemical Company. The silicone breast implants were taken off the market. Well, fast forward to 2019, if you were having breast augmentation, it's probably going to be silicone.
Right.
It's not the silicone that's the problem. It's not the mesh that's the problem. It's just part of the deal.
Right.
So as far as vaginal surgery, that's one category. The robotic stuff can be lots of different things. The robotic stuff for pelvic floor reconstruction can be just like repositioning the bladder robotically, repositioning the apex of the vagina robotically. Sometimes you have to reconstruct the top and the bottom of the vagina, and you put a Y mesh on the top and the bottom. You tunnel it behind the back of the abdomen and sew up to the sacrum to pull everything up.
Yeah.
And so there's multiple things you can do robotically, but most of the people that do urogynecology usually feel comfortable doing it whichever way.
Right.
And so it's just another way of doing things. And some people it's beneficial, some people it's not beneficial for.
So back up a little bit. Talk about robotic surgery. Some people, it's not an actual robot in there, right? You are operating so tell them a little bit about what it looks like to have robotic surgery.
So robotic surgery, you just think of it as laparoscopic surgery. And laparoscopic surgery is where you do surgery through small little holes, 5 millimeter to 12 millimeter sleeves are put into your abdomen, and you kind of distend your abdomen up with gas, and then you do the surgery. Well, surgery laparoscopically, you have instruments that are kind of straight.
Right.
And they just can and if you were watching me on film right now, you'd see me doing hand motions right now as we speak.
There's no wrist.
There's no wrist
in laparoscopic.
It's all straight arms. And so sometimes when you have like more tedious surgery, or you have to do like suturing in surgery, it's harder to do laparoscopically. And so the robot came along to make those surgeries more easier to do. And then there's a bigger amount of people who could have minimally invasive surgery.
Right. That's awesome. So the robotic, just to give you guys a visual, when we used to do robotic surgery together and Dr. Windom would scrub in, we would all place ports, then he scrubs out. He has a little console over in the corner, and you've got one lens, camera lens, correct, on each eye.
Correct.
Right? And so he sees 3D into the abdomen where we see it flat on the screen, but he also holds, they're like little finger holders, and he can, it's like his hands are the robotic arms.
It's like you sometimes will see in movies or something where or like Avenger movies and things like that, where they'll put their hand into a glove, and as their hands move in the glove, the arms of whatever character they are move. It's the same thing. The robot's not doing anything.
Right.
It's me with my hands in there, but it allows the instruments to mimic how my hands move, and that's how it works. But between the 3D and the precision of how your hands move, it helps the surgery tremendously. The only problem is there's no tactile feedback. So you can't feel something, so you can't tell how hard you're pulling, how soft you're pulling. You can't feel things, but as you do them more and more, you almost feel like you can feel it.
Right.
You just get a sense.
You learn over time.
Exactly. You learn over time.
Absolutely. That's so cool. So I want to talk a little bit about fibroids and endometriosis. Now, one of the questions I have, just for being of my age, and a lot of my friends are trying to get pregnant and have babies, and endometriosis, and correct me if I'm wrong, is not something that you heard a lot about maybe 20 years ago, 30 years ago, or maybe there wasn't a surgery. I don't know. I'm asking. I feel like it's more prevalent now. You hear a lot of people saying, or I'm hearing more of it. I could be completely wrong. But what is endometriosis? What is that?
So endometriosis is where you have uterine lining cells growing other places than the uterine lining. And the way to think of it is every month, when a woman has her menstrual cycle, she's sloughing out her uterine lining to start over the next month. And every month you're starting over to get pregnant. And if you're not pregnant, you slough off the uterine lining and start over again. And so there's theories of how endometriosis happens. Some people think you could just be born with cells inside your pelvis that just change into uterine lining cells. But most people, me included, believe that endometriosis probably comes more from an abnormal immune system and what's called retrograde menstruation. So when you have your period, your uterine lining comes out through the cervix, but sometimes when people's periods are heavier, the uterine lining can go backwards through the fallopian tubes, and that's called retrograde menstruation. And then the uterine lining can land on the ovaries, can land on the pelvis, wherever. Most people's immune system can get rid of this endometrial lining. But people who have endometriosis, there's something with their immune system that doesn't work as well to get rid of the endometrial lining. And for the longest time, people tried to come up with immune boosters and things like that to help out, and it didn't always work. So then they came up with ways to turn off estrogen, so you didn't have any estrogen, and almost put you in menopause, and so the uterine lining cells would die. But eventually you have to turn the estrogen back on again, especially if you want a baby. And so as people didn't talk about it and people didn't do much about it, because back in the day, the only way to do surgery is with a big incision on your abdomen.
Right.
And so when someone came and complained about these types of things, is it bad enough to do a surgery on your abdomen and be out of work for 6 weeks?
Right.
Oh, I don't know if it's that bad.
Right.
And then also in the old days, and this is predating me, if someone had these complaints, and they'd been trying to get pregnant for 2-3 years, and they had these complaints, somebody would just probably do a hysterectomy and take out their cervix, their uterus, their tubes, and their ovaries, and that was the end of it, and they wouldn't have these problems anymore.
Right.
So as laparoscopic surgery came along, it was a minimally invasive way to fix this.
Okay.
And also with laparoscopic surgery, you could look inside the abdomen and see what's going on.
Right.
Because there's no modality to diagnose this before surgery.
Without seeing it.
Yes.
Right.
Some people will say, we'll do a CAT scan or an MRI or ultrasound. It doesn't really tell you. It's more the symptoms and trying a couple things, and then the risks and the benefits of the surgery. And to people who are suffering from this, they're oftentimes wanting to go to surgery as soon as possible. But you try a few things and see if that helps out, and then if it doesn't, then you move on to surgery.
Just kind of like with anything else, you got knee pain, you're going to try physical therapy things first before you go into a scope, until you go to scope.
Exactly.
So maybe it's not so much that it hasn't been around. It's just, it's easier with laparoscopy. Is that what you're telling me? It's easier
It's way easier to do it with laparoscopy. And also, you hear about it more because you're at the age of people talking about getting pregnant. So people talk about these things. And also, 30 years ago, if a woman had a hard time getting pregnant, she probably didn't talk about it. And she wasn't saying things. And there wasn't the internet. And there wasn't Google. And there wasn't all these things. Now, people talk about things, which is way better.
Right.
And so in the dialogue, as well as the information that you can get that's so readily available, it makes people realize that there's treatments for these things, and they seek out people like me.
Right. Now, you also do a lot of surgeries you and I did together with some of the fibroids.
Yes.
And you, correct me if I'm wrong, you do a lot of big fibroids. We do a lot of difficult, some of the more tasking fibroid surgery. So a little bit, how does a fibroid form? Is it genetic? Does it just happen? Is it food? How, and you know, what is the kind of the pathophysiology behind that?
So fibroids are benign tumors in the muscle wall of the uterus. Now, sometimes they can be on the outside of the muscle, the inside of the muscle. Sometimes they can be inside the uterine cavity. But they're just benign tumors. There is a possibility they can turn into cancer, but at worst, it's 1 in 350, so like a 0.3% chance of being cancer. It's slim. But so fibroids tend to be genetic, and you see it in African American women way more than any other population. And the fibroids, no one knows exactly how they grow and what happens, but there are some people who think that certain foods you eat could make things worse. There are people who think that obesity can make things worse. But in general, it's pretty much genetics. If I have a person who comes in with fibroids, it's rare that she does not have someone in her family who has this problem.
That's interesting. So it's mostly genetic.
Mostly genetic, yes.
Mostly genetic. And you do robotic.
Correct.
Okay.
And the fibroids, with these fibroids, I mean, they can be, 10, 12 centimeters. They can be big. And they're a major cause of pain. They're the number one reason that women in the United States have hysterectomies. And they also are a major cause of infertility. And they can obstruct an embryo from implanting in the uterus. They can cause the uterus to be an abnormal shape. They can block fallopian tubes. And so they can do a lot of things. And so in doing surgery to remove fibroids, you're oftentimes removing the fibroid to help with the pain, but you also have to leave them with a functioning uterus that's going to be able to carry a baby. And so that's why it's a little more difficult, because when you do the surgery, you have to be cognizant of this person's going to go on to get pregnant and grow a 7-pound baby in there and stretch, and you need to make sure what you do.
There's enough there.
Yes, what you do, you have enough uterus left over, and it all works, as well as the uterus has a normal function.
Right. Right, which, guys, I've been physically in surgery with him before, and it's impressive what you can do.
Well, thank you.
It really is very impressive what you can do. So now some fun questions.
Okay.
Just for my own personal gain. On average, how many surgeries do you think you do in a week?
Well, I give a perspective.
Okay.
So the average gynecologist, the average OB-GYN, does 3 major surgeries and 3 minor surgeries a month.
Okay.
And I do 4 major surgeries and probably 3 or 4 minor surgeries a week.
Right.
And then I also do probably 3 C-sections a week.
Yeah.
And so, I end up doing probably 110, 120 C-sections a year. And whereas the average gynecologist probably does 40 or so, or 50.
Right.
And so, so when you do a lot of surgery, you get pretty proficient at it.
I was about to say, what he won't say is you get real good at it, because he is, guys. He totally is. So,
well, I think the OB-GYN model is not the greatest model, because it's hard to believe that a person that can be there for you when you're 25 and you need birth control pills or something, and that person can then be there to deliver your baby, then that person can then be there for problems afterwards, then that person can handle your hormones, and that person can be your primary care doctor, and that person can take care of you when you're in your 60s, 70s, 80s. It's hard to be good at all of that.
Yeah.
And OB-GYN residency programs are struggling with this too, because that person doesn't exist as much anymore. And so people are becoming
Specialized.
Highly
specialized.
specialized. And some people just are in the office. They're just office gynecologists, and they are very good at doing office gynecology. And if they have a problem, they refer things to someone like me.
Right.
And so there's a lot of this that's changing. And as time goes on, you're going to see more of this. And the one thing that people are really going to be shocked at that they see is now there are laborists, which are like hospitalists.
Really?
So if you were to get pneumonia and your primary care doctor sent you to the hospital to be admitted to the hospital, you wouldn't see your primary care doctor, you see the hospital doctor.
Right.
Well, now there are people doctors who stay, OB-GYNs, board-certified OB-GYNs who stay on labor and delivery, and there's a business model. My group does not do it, but there's a business model where if you go into labor, you go to the hospital, and the hospital doctor delivers your baby. And the hospital doctor takes care of you, and then when you are done, you come home, and then 6 weeks later, you go see your OB-GYN who took care of you through the prenatal care. Patients are understanding this and are seeing this.
Yeah.
I don't know where this like medical model will go.
Right.
But
it's an interesting concept.
It's a very interesting concept.
Just like you were saying, the hospitalists.
Yes.
It's really interesting.
And 20 years ago, nobody would ever believe that would work, and now they do.
Yeah.
Pediatricians are this way. I mean, you want to make sure your pediatrician comes to the hospital to see your baby. Well, now there's a hospital pediatrician.
Right.
Who is very good at every day seeing babies and looking at newborns, and they're not in a rush to get to their office.
Right.
And they will take the time, and then when you leave, they have a full report, and you take that full report to your pediatrician.
Right.
So it's just things are changing. There are younger doctors that are coming into this world who have a better life-work balance, and they think about these things, and so it's. I'll be curious to see what happens in 20 years.
That's interesting. So 2-part question for you. First one is in concerns to gynecological health, so women's health particularly. What are some of the bigger I'm saying mistakes, but that's not the word I want to say, but that's the only word that's coming to mind right now. What are some of the mistakes or some of the preventative things you would like to see women doing more of? Is there anything from your standpoint, especially with all your reconstruction stuff? You always hear things about the Kegel. And what are some things, does that actually work?
Kegels do work, and I will tell you, your quote-unquote pelvic floor muscles, or the muscles that do a Kegel, if you're really good at that, then it does decrease the chances of you having urinary incontinence down the road. Mm-hmm. And so women who do Kegels, and they do it throughout their pregnancy, and after the delivery they do that, it's no different than the person who is doing, some kind of exercises for their leg to get their legs strong before they have knee surgery.
Right. And
then they rehab and they do physical therapy, but they were already ahead of the game before their surgery.
Right.
It's the same thing. So Kegels are definitely something that people could do. I think some of the biggest mistakes are listening to myths that there are in the OB-GYN world.
Yes.
There's lots of myths on birth control pills, the pluses and the minuses, breast cancer, who gets it, who doesn't, hormone replacement therapy, C-section versus vaginal delivery. There's lots of myths, and oftentimes the conversations are amongst friends, or they're amongst the internet. Mm-hmm. And you can have a vocal minority on the internet who has a platform of we're against C-sections, or we're against birth control pills. Right. And I think that the best thing that women can do is take ownership of their own health care. Yes. And the way they do that is get as much information as you want from the internet, and get all of this, but show up at the doctor's office with your list.
Yeah, ask the questions.
And the doctors, we are more than happy to answer questions, but oftentimes they'll be like, all right, any questions? And the patients will be like, oh, they'll go blank. And then they're driving home and they're like, oh my God, I could have asked that or that.
Right.
Ask the questions, and if your doctor is bugged by the questions that you're asking, ask a different doctor. Because there's going to be doctors who should be able to take care of that. And so I think that the knowledge is power, but be ready with your questions to ask and have a list of questions.
So the second part to that is, now outside of just, the Kegel exercises we were talking about, do you see better outcomes in women who eat healthier and exercise regularly? Do you see better outcomes in both obstetrics and in, after? Do you see it?
So for sure in the obstetrics world, and there's a lot of good data talking about the healthy woman and the woman who has a ideal body weight BMI and how they do having babies. They have less of a C-section rate. They have a quicker return to normal activity. So that's for sure. People who smoke, smoking makes your connective tissue weaker.
Yes.
And in the urogynecology world, with your bladder falling, your rectum bulging, they're all hernias. They're tears in connective tissue. And so if you're a smoker, you're more likely to have an ACL tear, an Achilles tear, a shoulder, rotator cuff. We're also more likely to have problems in my category. The same thing in obesity. Obesity, oftentimes the weight, and if you carry your weight in your abdomen, there's just more pressure on the pelvis, more pressure on the pelvic floor, and that can increase your risks of leaking urine when you cough and you sneeze, or having uterine prolapse. So definitely a healthy lifestyle helps out in this category.
That's awesome. So let's say that somebody listens to this and they just fell in love with you, because they all will. How can they get in touch with you? What are some of the modalities that we can give our listeners to get in contact with you?
So they can get in touch with us by looking us up on the internet. Our website is www.OB-GYN Associates
Does that mean you have other locations?
So we have we have an office in Marietta that's right connected to Keystone Hospital. We also have an office in Woodstock.
Okay. And then, guys, you can also do a Google search. You can find, I will put the website in the show notes. I will put a phone number to your Marietta office. Now, do you see patients anywhere else?
I do not see patients in the Woodstock office.
Okay.
I only see patients in the Marietta office, and it's mainly because I operate 2 days a week.
Right.
So it's just easier just to be in one place.
Right. But I'll put everything for both offices, both practices for you in the show notes. And then you can also check him out with a lovely, beautiful photo of him on the WellStar website. He will be on the website as well. But Doc, thanks again for coming in.
Sure.
This has been awesome. I really appreciate it. And I look forward to working with you again
I've looked forward to it, and it's been great seeing you and seeing where you've come in your life. I'm very proud of you.
I appreciate that. Thanks.